our OB/GYN department in Prince Sultan Military Medical Center. So we are going to talk today about diabetes in pregnancy, and we are going to have a second half of presentation focusing on thyroid problems related to pregnancy. So diabetes, there are three types of diabetic disease that we encounter during pregnancy. Pre-pregnancy or pre-gestational diabetes mellitus is type 1 and type 2, and which does, the patients start in the first trimester with already known her disease and with medications that well established. And this is majority of the diabetic population that we see during pregnancy. However, the bulk of diabetic disease that we encounter is gestational, or the diabetic disease that develops usually at second or third trimester of pregnancy. You know probably from internal medicine what is the distinguishing features between type 1 and type 2 diabetes. Type 1 diabetes, they have total or absolute insulin deficiency. So pancreas is not able to produce any insulin. So, and that is commonly caused due to autoimmune destruction of beta cells. And type 1 diabetes is usually associated with early age, usually in childhood. However, nowadays we have more and more adolescents and adult age that may represent first time picture of type 1 diabetes mellitus. Whereas type 2 diabetes is usually related to something called metabolic syndrome, and which is the main core of this syndrome is insulin resistance. So these patients are chronically exposed to hyperinsulinemia because of deficiency of receptors response to the insulin, which is in the blood circulation, but cells are not able to use this glucose, which is there, because there is no correlation and there is no good attach or recognition by the receptors. And that ultimately leads to premature atherosclerosis. Patients are prone to develop polycystic ovarian syndrome and chronic hypertension and abdominal obesity. So this is just a diagram showing what are the differences between type and type 2. How do we diagnose diabetic disease in the non-pregnant state? Probably you studied this before, so we have American Diabetic Association criteria. What are the readings when we expose the patient to glucose tolerance test? We give them some glucose, and then we measure either with fasting and then 1 and 2 hours after this glucose juice. And then according to the readings, we categorize the patients, are they really diabetics or not? White classification is still valid, and you can see that A category is gestational diabetes related to pregnancy. So usually A1, these are the patients with milder disease who need just lifestyle modifications and including diabetic diet, whereas A2, gestational diabetic disease, is more severe, and these patients usually need medical treatment, commonly with insulin. So what's going on with the pregnancy? There are two important things that are very important to memorize or to be aware of. That in pregnancy we have something called accelerated starvation, and we have profound insulin resistance. So what accelerated starvation do is that it does lower fasting glucose levels. So patient is early morning, very hypoglycemic, and sometimes she's not even aware. But this is physiological. And we have, due to accelerated starvation, we have increased ketogenesis because the body is having defensive mechanism where needs to actually produce some energy. So it's actually forming ketones bodies, which might actually accelerate into starvation ketosis, where we have actually full picture of ketoacidemia in the pregnancy, and that actually worsens in diabetic patients. So we are talking just about normal things that we see and that we can actually diagnose and prove during pregnancy. So normally in first trimester, fasting blood sugar falls with nadir of 3.5, so it's lower than in non-pregnant state, and we have reduction in epinephrine and norepinephrine. In third trimester, on the other side, we have start to see more insulin sensitivity and more resistance, because sensitivity decreased by almost 56%. So why we have increased resistance in insulin in second and especially in third trimester? Because physiologically there are hormones produced by the mother and by the placenta which are pro-diabetic. So they are actually putting patients under the risk ultimately to develop actually gestational diabetes. So patients who are having features, characteristics, genetic predisposition to develop gestational diabetes is gonna be very easy for them in comparison to the non-pregnant state. So you will see many of your aunts, grandmothers, and so on. So they started to have gestational diabetes in pregnancy, and ultimately they had type 2 diabetes later on in life. And this is all kind of trigger for them because of all this pro-diabetic hormonal state. And the important thing that, as I said before, hypoglycemia unawareness. So if physiologically fasting blood sugar falls, the patient will be hypoglycemic and she will not be aware because there is no epinephrine to keep her like, I'm sweaty, I'm shivering, there is something wrong with me because of the also suppression of these hormones. And sometimes on the other side, even acute DKA can happen and the patient is not really aware. So what's happening on the other organ system? We know that GFR increased due to plasma volume increase, and the whole circulation actually is increased by 50%. Due to increase of GFR, we have decrease in the creatinine levels, and protein excretion might increase up to 300 milligram per day. So this is all physiologically that we expect. And again, we have physiological anemia due to pregnancy and hypercoagulability. Because again, as I said, for the diabetes, pro-hormonal status of pregnancy actually put the patients under the risk of coagulopathies, thrombosis, thromboembolism, and so on. So what is the pregnancy effect on pre-gestational diabetes? So the patient is already diabetic, she started her pregnancy, so there are three things that we are always having challenges with. It's how to achieve good or optimal glycemic control, what to do if the patient already has microvascular complications, and did we assess and is the patient having already multi-organ system problems, and we might expect a deterioration in a pregnancy. So as I said before, it's very important to remember that increased risk of fasting hypoglycemia, which is often unrecognized, and insulin resistance, which happens later on in pregnancy, which which put patient in the risk to increase ketone production, ketosis, ketoacidemia, and so on and so on. So 30 to 40% of women will develop severe hypoglycemia in the first half of pregnancy. We are talking about pre-gestational diabetes, so patients who are already type 1 or type 2. And usually they will tell you, oh, I have low blood sugar in the middle of the night. I wake up at 3 in the morning or of 2 in the morning, I'm shivering, I'm sweating, I need to drink juice, I need to have chocolate. Because this is because of the physiological effect, and plus the patients are diabetic, so it's like double things happening to them. So greatest risk is for the patient who are actually having those episodes of severe hypoglycemia even before pregnancy, the patient with gastroparesis and hyperemesis gravidarum. If the patients had intermittent, from time to time, maternal hypoglycemia, it doesn't cause any adverse effect on fetal or neonatal outcomes. So this is very important. Hypoglycemia does not affect fetus, okay, in utero, but neonatal hypoglycemia could be very bad. So during pregnancy, it's okay, and even if the fetus is exposed all the time, however, postnatally we'll talk about this, how it can be bad for the neonate. So this is just summary of other organ systems and how that how diabetic disease may worsen or can change due to pregnancy itself. So you can go through these slides at home. I just want to point out that any pregnant patient might have diabetic nephropathy, so we have to keep eye on renal function tests every trimester at least. We have to think about hypertension and risk of preeclampsia, fetal growth restriction, and fetal death. Other vision or eyes should be checked by yearly, because we could expect in non-compliant patient worsening in the vision. They might have retinal detachment, they can have hemorrhages, and so and so. So this non-proliferative retinopathies are expected. So that's why yearly they have to go and have a checkup by ophthalmologist. And very often, first time they see ophthalmologist during pregnancy, because we are keen on this side. Cardiovascular disease is usually stable. No many reports actually pointing into that heart and cardiovascular system in general may worsen. And neuropathy is not bad for diabetic patient during pregnancy, because again we have to think these are young population, reproductive age. These are not elderly women that we expect actually neuropathy in them. So when we talk about gestational diabetes, so it's glucose intolerance, first time recognized during pregnancy, and usually after 20 weeks of gestation, sometime after first half. So if you have a patient who has symptoms or readings of coincidental high blood sugars in the first half of the pregnancy, you have to think that this patient might be already type 1 and type 2, but she was not diagnosed. So it was the first presentation during pregnancy. So gestational is milder disease which occurs later on in pregnancy. So pathophysiology, again, we talk about insulin resistance, because pro-hormonal effect, we have human placental lactogene, progesterone growth hormone, and others which are pro-diabetic, and we have a lower islet cell function. So, and there are some researches coming out where more and more specific genes are related to development of gestational diabetes, and this is still under research. How do we screen everyone or just selected population? It's not uniform, but universal screening is mostly developed in many countries because of the predisposition, lifestyle, obesity is in rise, and so on. So when do we screen patients pregnant? Is usually between 24 and 28 weeks. And why exactly at this time? Because we are trying to balance sensitivity and specificity. If we do it much earlier, let's say 20 weeks, we might have we might miss patients who might develop diabetic disease later on in pregnancy, and we know it does actually boom at later in second and third trimester. And again, if we do it late, at 32 weeks, 34 weeks, we might miss actually opportunity to treat. We might pick larger number of patients who are diabetic, but however, there is limited time to modify anything or to lower or adjust glycemic status before the patient gives birth, which is the main goal. And all these patients should be screened with the risk factors. So patients who are having bad outcome in the last pregnancy, who are obese, who are from certain ethnicity population should be screened even before pregnancy. And some of these patients who are screened at 24 to 28 or who are screened earlier, 10% we might miss, so they have to be rescreened at exactly 24 to 28 weeks, so not to miss anyone. How do we do it? One step or two steps? So if we go by one step, what we do here in Saudi Arabia is giving them 75 grams of glucose. It's like a juice, which is not really tasteful. It's not tolerated by all women, so many of them are just abandoning this testing. And if we have one abnormal reading means there is an element of GDM, okay? And two readings are definitely the patient is having gestational diabetic disease. Then we have readings, but by which we go and we categorize these patients. In states, they do actually two steps approach. First step is the patient is not fasting, she takes and she comes and takes 50 grams of glucose, and if the readings is 135 or 140 milligram per deciliter, the patient might need to go for another testing, which is three-step testing that we do in Saudi Arabia, but they give them 100 grams of glucose. So if the patient, 80% or more of women with more than 200 milligram will actually fail 3 hours GTT, and they're already after first step actually diagnosed as GDM. So when we talk about GDM 1 or 2 readings, so it's kind of controversial, and different societies are actually giving different recommendations. But definitely 2 high readings, it is abnormal. 1 reading, they might not need a really close care and close observation and monitoring. However, they have to be instructed about diet and exercise, and from time to time they have to see diabetic team or OBGYN to check on the reading, especially toward the end of the pregnancy. So how diabetes affects pregnancy, because it does have several negative or adverse effects, such as it does increase 2 times increase serious injuries at birth, because some of these babies are prone to be macrosomic, causing cervical dystocia, and then high risk for cesarean section, and of course these babies, due to several issues, might be at risk of admission to NICU. So as I said before, if the patient is diabetic, even with gestational diabetes mellitus, they might develop gestational hypertension and preeclampsia. They might have risk for the operative delivery infection during and after surgery. And if hypoglycemia does occur, it's not bad, as we said. So we hate to see hyperglycemia status. Hypoglycemia are causing sickness for the mother, but there was no harm on the fetus, which is important, and it does not cause embryopathy, so patients could be reassured. Diabetic patients, especially non-compliant, are in a risk to develop stillbirth and pregnancy losses, up to 4 to 5 or 4 to 6 times more than non-diabetic population. Fetal death. So the main reason why we follow the diabetic patients, why we are always very, very concerned, because they are in the risk of developing stillborn babies. So all of a sudden, everything was well yesterday, well-grown, chubby baby on ultrasound, normal LICOR, normal Dopplers, everything was well, but tomorrow the patient comes and there is a fetal death. So what are the causes? So there are 2 theories that this chronic fetal hypoxia, we know that they are exposed to chronic hyperinsulinemia, hyperglycemia, then hyperinsulinemia, and hyperinsulinemia, it's there because cells cannot use the glucose as a growth hormone, as something, the main energy source to live, to grow and develop. So this chronic fetal hypoxia ultimately going into acidosis, chronic acidosis, might cause intravascular thrombosis, and eventually death, depends on which organ. That's why they are prone to develop anomalies. And on the other side, the worst thing is intrauterine fetal death. And there is another theory that severe fetal hypertrophic cardiomyopathy, so they have a really dilated cardiomyopathy, especially on the septum. So if we see a large, thick septum, we before we're measuring it above like 5 millimeter, that might actually cause suppression on LVOT, left ventricular outflow tractile aorta, and might cause a sudden death. Okay, so that's difficult to screen, but who is working in fetal echocardiography always pays attention on septum and looking at is it bulky, is it hypertrophic or not. Again, poor glycemic control, fetal macrosomia, if the patient has already renal disease, these are all factors that might lead into stillbirth of the baby. So what about anomalies? Again, the same mechanism. It's not really definitely concluded or proved, and there are some animal studies, they elucidated constant or chronic hyperglycemia causing oxidative stress and then oxygen depletion into developing organs, whatever the organ it is. Is it kidney? Is it a limb? Is it an eye? Is it part of brain? It might increase, it might cause a lack of oxygenation, lack of vascularization, and then eventually that organ will not develop properly or will be actually malformed. How can we directly think about relation of the glycemic control and congenital malformations? The only tool that we may use is hemoglobin A1C. So ideally, we should start pregnancy or maintain hemoglobin A1C throughout the pregnancy around 6. That would be ideal. And as hemoglobin A1C increase, the risk of anomalies does increase. And the most common ones are cardiac and CNS. And there was a good systematic review where they look at the birth defects between pregestational and gestational diabetes. And they have found that 46 of possible 50 defects, 46 were found among patients with pregestational diabetic disease. And the most common sacchalogenesis, holoprosencephaly, longitudinal limb deficiency, and others. So and you can see here the odd ratios, how they are high, and I think patients preconceptually should be counseled about these risks so they will be more compliant, more keen to taking control of that disease. On the other side, gestational diabetes is causing less birth defects, and just 12 out of 50 or 56. And this is why, because it does happen in second and third trimester, so babies already embryopathy is done within the first 12 weeks. So actually, just the growth or hyperplasia, it does continue, and that might be affected by gestational diabetes, but not like major organ malformation. And gastroschisis, interestingly, actually, there was something protective. There was no more increased risk for this problem. You know, gastroschisis when you have abdominal wall defect, when bowel is outside the fetal tummy. So what about risk of diabetes on fetus and neonate? So we talked about, in general, risk on pregnancy, but we know that uncontrolled diabetic disease actually cause overgrowth of the baby or super growing babies. So we call them large for gestational age, and there are two either ways to categorize them, either by grams or kilograms for kilograms, or to be above 90th centile for certain gestational age. And we have a growth centile where we can follow it. Again, it's due to commonly fetal hyperinsulinemia. So what are the risks, associated risks causing or putting patients in risk to develop LGA is obesity. So I wrote 3 times intentionally just to remember, for you to remember. If mother is obese, the worst or the highest risk is to develop baby with LGA. And then maternal weight gain during pregnancy and other factors. And don't forget that the patients who have especially pre-gestational diabetes mellitus might be in risk of developing small for gestational age babies. And these are patients who have microvascular disease, who have multi-organ failures usually, or certain organ failure. So that placental development could be disturbed or altered. So they can have microvascular thrombosis or underdeveloped trophoblasts, which are very important for gas exchange on the level of the placenta. So these babies could be followed, should be followed and observed for both ways, either small or being large. And risk factors, patients who are smoking, who have placental insufficiency, hypertension, and other comorbidities. So what about neonates? So neonates could develop, if they are exposed chronically to constant hyperglycemia, hyperinsulinemia. When you cut the cord, umbilical cord, all of a sudden there is no anymore transfer of glucose. The baby will go into hypoglycemia, and this is the worst that we might see in the babies of diabetic mothers, because the main fuel, that instant energy that baby has to use, or all of us, is glucose. If the brain does not have immediate glucose after first breath, in the first hour, there are very sensitive cells in the brain, like choroid plexus, that these babies might have micro injuries, okay, like micro ischemic injuries, and could have consequences for lifelong. And that's why nowadays I'm very interested in this field, corticosteroids. When we give the patients, it might increase glucose levels, and how that impact if the patient is delivering during that hyperglycemia status postpartum. They have found that those babies with hypoglycemia could have worsened academic achievement, behavioral problem, depression, other things and even lower IQ in late puberty. They measure them at age of 9, age of 17. So this neonatal hypoglycemia is very bad. So this is very important to remember. And of course, they could have some electrolyte imbalance, like hyperbilirubinemia, hypocalcemia, and the long-term effect that these babies might develop type 2 diabetes from diabetic mother, usually at childhood, obesity, and there are some reports going with that it could genetically be predispose them to develop autism spectrum disorders. So preconceptually, we always have objectives to assess patients' condition, optimize glycemic control, start folic acid, and always educate patients. The better they are educated, the better they will take care of that disease. There are certain checkup lists that we go through before the patient gets pregnant, just to be sure that she is optimized, in an optimized status before she gets pregnant, okay? And then, of course, when the patient is throughout the pregnancy, we watch 3 things. So we watch always glucose readings from home, and then reinforcing diet with diabetic educator or dietitian alongside with us, and ask patients to exercise pre and during pregnancy, because we want them to walk, to ambulate, to do some yoga or whatever, just to lower glucose after the meals. And again, our aim is to keep fasting below 100 and to keep 2 hours postprandial below 120. So these are two readings that are very important. Every patient needs to know. If you have fasting above 100, that's not bad. There is something wrong. Either you ate a lot, like your quantity of meal was large, or calories, or the type of food you are eating, it does shoot your blood sugar. Hemoglobin A1C should be maintained throughout the pregnancy. There is nothing called in first trimester it should be 6 and then it should be 9 or 12. No, it should be 6 or even below 6 if it is possible, and it should stay the same, because each 1% of increase does actually reflect change in a mean glucose level by 30 milligram per deciliter. How do we treat? So you have to be aware that nowadays metformin could be actually as a start medical therapy, and other oral hypoglycemic agents. However, 2/3 of these patients eventually will need, in addition, insulin. So insulin is the mainstay therapy, and there are now so many insulin types, long-acting, short-acting, different companies where actually, and even syringes, it's very, very easy to be applied by the patients. So some data looking into, should we make it very tight or lose control or less tight control? So logically, if we have really very tight control, we will improve neonatal hypoglycemia. If we have loose control, then we have increased risk for the mother to develop with these high readings, preeclampsia, hypertension, cesarean section, because the babies will be a bit larger. What about DKA? The same applies as for non-pregnant state. Patients pregnant are in increased risk, around 5 to 10% might develop DKA. We talked about unawareness. They are actually having high glucose levels, but they are not aware. They are very sick, and the first thing that we have to exclude DKA. So again, we talked about the reason. There are some risk factors why the patients do develop DKA, either certain ethnicities or accelerated starvation. They had corticosteroids, they are having hyperemesis gravidarum, or infection. So usually for DKA there is a trigger: infection, hypoxygenation, hyperemesis. So if we correct the cause or the trigger, then the patient actually recovers faster. And this is the management where we have to admit those patients, start hydration. We have to correct electrolyte disbalance. If there is low potassium, we have to replace it. If it is low phosphate, we do replace, and we keep eye on these blood tests very frequently, like 1 to 2 hours until they are corrected, and then of course watch for the fetal status at the same time, because sometimes we can lose the babies in these episodes of DKA. So what do we do in regards of fetus throughout the pregnancy? So it's very important to consider high-risk pregnancy. It should be followed by maternal fetal medicine consultant, especially type 1 and type 2. These patients should have first trimester screening for congenital anomalies, and then we have to do fetal echo between 18 or 20, depends on which book, but usually the better, the earlier the better, to exclude major anomalies, and on echo fetal major cardiac anomalies. Then we closely follow up the fetal growth every 3 to 4 weeks. And then toward the end of the pregnancy, usually around 32 weeks, we do start a little bit more surveillance, like giving mothers fetal kick charts, doing some non-stress tests until we plan delivery. So when do we deliver patients with type 1 and type 2? It's usually around 38 weeks. If they are well controlled, we might even prolong to 40 weeks. GD1 diet well controlled around 40 weeks of gestation. When they are on insulin, like type 1 and type 2, usually 38 to 40 weeks. So every patient is individual, and we actually tailor the treatment and plan delivery according to its own status, readings, factors, previous histories, and a social environment that she's living in. So sometimes you will have patients, oh, I have to deliver earlier, although I'm diabetic at 36 weeks because I had fetal death at 36 weeks. So even though you try to counsel and try to push the pregnancy toward the end of 9 months, but it's very hard when the patient are psychologically affected by the previous experiences, or heard somebody had bad experience. So it's always balance. So all diabetic patients can deliver vaginally unless the baby's having estimated fetal weight above 4.5 kg on ultrasound. And we know that this late ultrasound is not always accurate. There is a risk of 10 to 15% of error measurements. And but still, diabetic patients even on lower estimated fetal weight might have increased risk of shoulder dystocia, difficult delivery, risk of cesarean, emergency cesareans, and that ultimately lead into several other adverse events. So it's better just to plan elective delivery when there is a macrosomic fetus on ultrasound. And very important, intrapartum. So the patient who is delivering, our aim is to keep blood sugar euglycemic, like euglycemic status, not low, not high. That's why we initiate insulin sliding scale every 1 to 2 hours. We do check, and then we add glucose, we add insulin. So we try as much as possible to maintain the normal levels, and this is just because of the neonatal hypoglycemia. We are afraid that baby will have sudden hypoglycemia, which has very bad risk on the future. And in postpartum care, if the patient was already on insulin, we actually lowered her doses to half or 2/3 of the pre-pregnancy dose, because there will be some still effect of the pregnancy, still hormonal hormones are not actually excreted, and the patient will be for some time in a good state with a half dose. However, they have to go back to the endocrinologist within 6 weeks of pregnancy, postpartum, just to be sure that the standard insulin doses are actually adjusted. Patients who had gestational diabetes, they are retested, so they go back to regular diet and they are retested between 4 and 12 weeks of life postpartum, just to be sure that they are not actually having diabetes type 2. I mean, they are not still in the status of diabetic disease even postpartum. And we know that 2/3 of these patients will develop type 2 diabetes within the next 10 years of their life. So it's very important that they are tested in postpartum period. Of course, we do discuss contraception for them. We monitor for postpartum infections, and we do talk about childhood risk of diabetes and obesity for their children. They can breastfeed regardless what medications they were on. And of course, on insulin, they can breastfeed, and there is very minimum exposure to these babies, and there is no long-term bad impact. So this is postpartum care for women. We said 6 to 12, now it's changed 4 to 12 weeks postpartum. And again, if their glucose tolerance test is high, they will be diabetic. If it is normal, they will be just normal population, but with instruction that next pregnancy they should actually watch for that they might develop again gestational diabetic disease, and if they have abnormal GTT but they're not still at the level of diabetes, they have to have lifestyle change and maybe retested after 6 months or 1 year to be sure, or yearly to be sure that they are not developing diabetic disease. So this is just summary what we do overall before pregnancy, preconceptual, in first, second, and third trimester, and in the postpartum. And these are the differences between 1 and 2, just for your exam. Is this clear?